Hi friends, this is Dr. Pratibha Dogra, respiratory and sleep physician practicing in Gurgaon. I have special interest in airway diseases, COPD, asthma and sleep disorders. In this talk, I'm going to take you through management of chronic stable COPD. To begin with, let's start with a case scenario. Mr. Ramesh Kumar, age 60 years, come to the OPD with history of cough, breathlessness, wheeze since past 4 years. Patient has complained of cough with lot of sputum, which is more during the early mornings after waking up from sleep. And there is progressive worsening of symptoms. The patient cannot walk even for a few hundred meters on level ground without stopping for breath. Also, there is a history of smoking 20 to 30 cigarettes per day since the age of 20 years. On examination, patient is breathless, pursed lip breathing is present, chest is hyperinflated, and on auscultation, wheezing is there. If we have a look at the X-ray, this is a picture of an emphysematous lung fields. The cardiac shadow is narrow. The diaphragms are flattened. The number of ribs that we can, intercostal spaces is more than 6. So all of this goes in favor of COPD. The clinical diagnosis for this patient will be COPD. The points that favor the diagnosis of COPD is history of smoking for 20 years, presence of cough, sputum, and breathlessness, and pursed lip breathing. So, and also the X-ray, which also favors COPD. Now, if we have access to spirometry, then we will go ahead with spirometry to establish the diagnosis of COPD. But in primary care settings, where the access of spirometry is not available, it should not be a reason for not initiating appropriate treatment for COPD. So once we have diagnosed this patient as COPD, we should be able to set certain goals for this patient. Now these goals would include that we want to prevent the disease progression. So as we all know that COPD is a progressive disease. So the first and foremost thing on our mind is to prevent the disease progression. Followed by, we should aim at relieving the symptoms, improving the exercise tolerance, improving health status, identifying and treating comorbidities, preventing and treating exacerbations, and preventing and treating complications. So we will go through all this one by one. The first thing that comes is prevention of the disease progression. And the first and the foremost, most important thing that can prevent the disease progression is quitting smoking. So we should put in all our efforts. We should counsel the patient, we should convince the patient about this, and should make the patient give up smoking. The best thing that can be done for a COPD patient is to make patients stop active and passive smoking. One cigarette almost decreases your lifespan by 11 minutes. Apart from counseling and convincing and talking with the patient, we can help them by giving nicotine replacement in the form of, now that is available in the form of a chewing gum, dermal patch or nasal spray. So this helps the patient in quitting smoking because this decreases the withdrawal symptoms. Other products that are available in the market to help in quitting smoking is varenicline and bupropion, but this has to be prescribed by the specialists. Even in today's time, in rural India, 40% of the households are using the biomass fuel for cooking. And if we are practicing in rural area and we know that the patient has exposure to the biomass fuels and smoke, we should also talk about how they can prevent this exposure. Now, just to talk about the prevention, we should be able to tell them that they should improve their kitchen ventilation, they should have a chimney in the kitchen, they should have an exhaust fan, or they should have a low smoke chula. The best thing is to replace the biomass fuel with LPG. But if that is not a possibility, they should be able to adopt the above steps to prevent exposure to the smoke. So after we have done our bit to, on prevention of the progression of disease, we should look at the management of COPD to relieve symptoms. And as we all know that in COPD, because of loss of elasticity of alveolar attachments and destruction of the alveolar attachments, it leads to bronchoconstriction. Hence, the bronchodilators are the first drug of choice for treatment of COPD. Bronchodilators that must be given for daily use for reducing symptoms are long-acting antimuscarinics like tiotropium or long-acting beta agonists like salmeterol and formoterol. Bronchodilators for use in case of increased symptoms or acute exacerbations are short-acting antimuscarinics like ipratropium and short-acting beta agonists like salbutamol. Tiotropium is the drug of first choice for treating stable COPD. Tiotropium has been shown to provide maximal bronchodilation. It reduces exacerbations, reduces hospitalizations, improves symptoms and health status. Dose of tiotropium is 18 micrograms once a day, and it is available in all devices like DPIs and MDIs, which can be used with or without spacers. If symptoms are not adequately relieved by tiotropium, then we need to add a LABA. So LABAs, for example, is formoterol and salmeterol. This can be, usually we need to give it twice a day, unlike tiotropium, which is given once a day. But before we think of adding a LABA, we should check for adherence and correct technique for using the inhalers. However, LABAs alone in an inhaler device may not be available. Hence, we often need to add a combination of inhaled corticosteroid plus LABA, which are more easily available. But ideal indications for adding inhaled corticosteroids in the patients of COPD are when the patient has FEV1 of less than 60% predicted on spirometry, there is an increased frequency of exacerbations, which is like more than 2 per year, or a patient has asthma COPD overlap syndrome, or we have seen there is sputum eosinophilia. So the available inhaled corticosteroid plus long-acting beta agonist combinations are formoterol plus budesonide and salmeterol plus fluticasone, which are again available in all the devices like MDIs and DPIs. Bronchodilators for use in case of increased symptoms or in acute exacerbations. For this, we are using short-acting beta agonist or short-acting muscarinic antagonist like salbutamol, ipratropium, or salbutamol plus ipratropium. Other drugs that can be used as an add-on therapy. Low-dose theophylline like 100 to 300 micrograms once a day, oral prednisolone and home oxygen. Now this is in contrary to the usual practice that we see in the rural areas. Theophylline is always considered as the first line drug for COPD. But whereas it should be an add-on drug. The first line drug are the inhalers and the first line is tiotropium. How do we decide which drugs to be initiated? Indian guidelines for diagnosis and management of COPD categorize COPD into mild, moderate and severe depending upon the FEV1, MMRC grade, exacerbation frequency and presence of complications. So if patient's FEV1 is more than 80 and the MMRC grade is less than 2 and frequency of exacerbation is less than 2 and has no complication, it will be defined as mild COPD. And if FEV1 is between 50 to 79, MMRC grade more than 2, frequency of exacerbation is again still less than 2, but there are no complications, it will be moderate. And in case the FEV1 falls less than 50% of predicted, MMRC is more than 2, exacerbations are also more than 2, and there are complications, so it will be labeled as severe COPD. The Modified Medical Research Council scale for breathlessness. So if we just go through the grading, we will see it increases from 0 to 4. 0 is when there is breathlessness on strenuous exercise. 1 is shortness of breath when hurrying on level ground or walking up a slight hill. The grade 2 will be on level ground, the patient walks slower than people of the same age. Grade 3 will be the patient stops for breathing after walking up about 100 yards or after a few minutes on level ground. And grade 4 will be that patient is too breathless to leave the house or breathless while dressing. Now this also is very important while we are taking history, that we are able to grade the patient. It is a very simple scale. It is very easy. It's very easy to fit in the patient into the MMRC grades. And if we know the MMRC grades, we are able to categorize the patient into mild, moderate, severe. So the treatment of COPD based on the severity is like if we have categorized the patient as a case of mild COPD, we will start the patient on short-acting beta agonist on SOS basis with an add-on therapy of tiotropium. If the patient continues to have symptoms, then the patient can add on tiotropium. If the patient falls in the moderate category, we start with LAMA continuously. So LAMA is again long-acting muscarinic antagonist tiotropium with an add-on therapy of methylhexanthines. And if the patient falls into the category of severe COPD, the initial therapy will be ICS, inhaled corticosteroid, plus LABA and or LAMA. So it can be ICS plus LABA or ICS plus LAMA. Again with the add-on therapy of methylhexanthines to ICS plus LABA and LAMA. So after we have done our bit to prevent the progression of the disease, we have done our bit to treat the symptoms of the stable COPD. Now we should look at how we can improve the exercise tolerance or improve the health status of this patient, and that is pulmonary rehabilitation. Pulmonary rehabilitation has been found to be the only one factor that decreases the mortality in COPD patients. And it is of utmost importance. We should not underestimate the importance of pulmonary rehabilitation in overall treatment of COPD patients. Now, walking is one thing that we can always advise to our COPD patients. Walking daily is one of the best forms of exercises for people with COPD. So how we can encourage the patient? We can tell the patient to start with walking as far as he can get without getting short of breath. He continues deep breathing as he walks. He stops to take a rest. So we spend a little more time on encouraging the patient to bring or to adopt walking as a routine in his life. Other thing that we should be teaching all our COPD patient is diaphragmatic breathing, because it helps strengthen the diaphragm and the abdominal muscles, allowing more air to move in and out of the lungs and without tiring the chest muscles. So this helps the patient go a long way in adjusting or adapting to the breathlessness which increases with the passing years. So teaching the patients of COPD pursed breathing also helps the patient in exhaling. So if they are able to exhale the air, the inflation is less in the lungs, helping the lung to work at a better capacities. Another very important thing to look in the patient of COPD while treating the COPD patient is identifying and treating the comorbidities. So if the patient is having, COPD is considered to be a multisystemic disorder. It is affecting almost all systems of the body because of the inflammation that is set in the body. It has been associated with anxiety and depression, with more prevalence of stroke in COPD patients, with diabetes. Because of increased work of breathing, there is a lot of muscle wasting is seen. Nutritional disorders are seen in patients of COPD. It is also associated with osteoporosis, acute kidney injury, myocardial infarction, arrhythmias, heart failure. The prevalence is again more in patients of COPD. Also, the patients experience more of fatigue, and if the patients can also have coexisting sleep apnea. So it's very important as a treating physician to identify the comorbidities and treat them effectively. So the common comorbidities that we should be looking at are hypertension, ischemic heart disease, arrhythmias, osteoporosis, and again give this appropriate treatment to the patients. Another very important questions that come in day-to-day practices is that would you use beta blockers in patients with COPD and associated ischemic heart disease and hypertension? The answer to this is yes. Beta blockers can be given to patients with COPD and associated IHD. The only thing is that we should be preferably using cardioselective beta blockers in such patients. Now, what we should be doing in preventing and treating the COPD exacerbations? And why it is so important to prevent and treat exacerbations? Because we have seen every time the patient of COPD has an exacerbation, there is a decline in the baseline lung functions of this patient. So the decline in lung functions is much steeper and it's much faster than in the COPD patients who have less of exacerbations. So the most important intervention that can help prevent COPD exacerbation is adherence to standard pharmacotherapy for COPD, and which is bronchodilators, tiotropium, plus formoterol, inhaled steroids, and low-dose theophylline. So if the patient is sticking to the standard pharmacotherapy, there are many chances that the patient can be saved from COPD exacerbations. Another thing that we should think of or we should advise the patient is vaccinations, because the most common cause of COPD exacerbation has been found to be infections. So any viral infection can lead to COPD exacerbation, or any viral infection that is followed by bacterial infection can lead to exacerbation. So to prevent exacerbation is that patient should be protected from viral infections like influenza and various bacterial infections. So influenza vaccination should be advised to all patients of COPD, which usually happens once a year in the months of September and October. And also pneumococcal vaccine is advised, which is given to patients above the age of 65 years and which is repeated every 5 years. So how do we go about if we diagnose the patient as having acute exacerbation of COPD? So we have to make some changes in the usual treatment of the patient. Adding steroids for a short term is recommended, something like oral prednisolone 10 mg for 7 days. We should switch the patients from inhalers to nebulizations, and the frequency of nebulizations should be increased. If the patient is having expectoration or sputum is purulent, we should be adding antibiotics. The choice of antibiotics is usually 4th generation quinolones like moxifloxacin or amoxiclavulinic acid. And depending upon the saturations, the patient may also need to be on low dose continuous oxygen for a while. And next will be to prevent and treat complications if any arises. Now, what are the complications that can be seen in patients of COPD? COPD patients, just because they have emphysematous lungs, they have bullas which are prone to rupture. The patient can have pneumothorax. Okay, they are more prone to having bacterial infections and pneumonia. They can have anemia, polycythemia secondary to persistently hypoxemic conditions. They develop pulmonary hypertension. In the advanced stages of COPD, patients can have pulmonary hypertension, cor pulmonale, and congestive heart failure. So in case we are treating the patient at the primary care level, and if we find any of such problems and complications have occurred in a patient, it is best that we refer the patient to the tertiary care center. So have I achieved my management goals? Yes. So if we are able to keep a track of the patient and we are able to take the patient step by step through all these steps, I'm sure that we will treat the patients of COPD very effectively and help them have a good quality of life. Thank you.